Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can be profitable and successful for years to come. This week on the Edge Podcast, I welcome Shirisha, and I'm going to have a problem with her last name, so I'm going to try, and then I'll have her repeat it when she gets on. Diapoli. She's the CEO of MedConverge, a healthcare RCM consulting firm helping independent practices thrive through smart tech-enabled solutions. She has over 15 years of industry experience. Suri specializes in billing, coding, and AI-driven automation. She's also very passionate about empowering RCM professionals to future-proof, I love that word, their roles in AI-powered healthcare landscape. So, Shirisha, welcome to the podcast.
Hey, Terry. Thank you so much for having me on this podcast. Honored to be here and excited, to discuss this topic. That's the buzzword, right? So, AI.
How do you pronounce your last name?
So I am Bamiredipalli. It's a lot of letters, but it's like super easy to say. You say it exactly how it's spelled. It's
Okay, good.
Bamiredipalli.
Bamiredipalli. Okay, good.
Yeah.
And do you prefer Shirisha or Siri?
Siri.
Okay,
Sirisha
perfect.
always makes me feel like I'm being told off because my mom only ever used it if she was telling me off.
Oh, okay. Well, it's funny because I have, when you have a smartphone and you say Siri, it might start
I know it
talking
goes
to
off.
you. So that's funny
Oh,
to
there
me.
you go. My phone went off. Yeah.
Yeah, see, mine
But
did too. Mine did too.
yeah.
So that's funny.
But thing is, I'm OG Siri. I don't get any royalty from Apple.
Oh, there you go. You're the original. I got it. I love that. So
Yeah.
so let's get into our topic here. I think
hmm
when you gave me this topic, I really liked it because it really just kind of hit home in some of the issues we're having right now in our industry. And I think there's a lot of revenue cycle management, which, are coders, billers, auditors, everyone in our space pretty much. They're a little concerned about what the future of AI, artificial intelligence, holds for them. So let me just ask you, just point blank, and then I've got some talking points that I just want to see what you think. So do you think that, will AI replace coders and billers?
No, absolutely not. The way we want to frame this, it's not so much about replacement as it is about reinvention.
Okay.
So we are going to have to reinvent ourselves as coders and billers.
Because it will have an
Because
impact. It definitely is going
it
to
will
impact.
have an impact. It will absolutely have an impact. So what we want to look at, and like you said, you love the word future proof, and that's a word, that resonated with me as well, because the future is going to be collaboration
Yeah.
between AI and human beings. There will always be a human in the loop. That's not, I don't see that changing for a long time yet. Whether it's from a liability standpoint, right? I can't say that, oh, my AI coded this, but who's your auditor? Who's doing the quality check? That's going to be the human in the loop,
Right. Well,
right?
and I look at some of these formats that, coders, billers, and myself as a coder and auditor, that we get to, review a note, and we get still handwritten notes by hospital. We get patient intake information, sometimes narrative lab reports that aren't always accurate.
Oh, yeah.
And we just don't have a uniformity that I think AI systems are always looking for their data dump. And
Mm-hmm.
so I think the coders out there, if you're a well-trained medical coder and biller, the contextual awareness right now that AI systems don't have, I don't think they won't have it eventually, but I think that there may be a little bit lacking in the deciphering and extracting pertinent information, especially illegible medical records. Yes, we still have those people.
100%. 100%. Yeah. Nuance and context, right? Those
Right.
are the two things. Again, well trained, uh, experienced medical coder, medical auditor, they would become more irreplaceable because, as you said, AI struggles with complex documentation, poorly written notes, illegible notes. I have practices where, they still like to use their paper notes and we're not able to,
Me
despite,
too.
yeah, you have so many AI dictation tools. They're like, Siri, like, could I still just do my notes? Like I still like to like put my anesthesia units and the time and things like that. I have this note. I've been using it forever.
Yeah, I know.
So
And if it's legible, and it can be scanned into the record, I tend to allow them to do that, but I try to still bring them forward into current, IT.
yeah. And then of course the clinical judgment, which only
Yes.
we have, we cannot rely on. We should not. Maybe some people would want to, but we should not. We ought not to rely on AI for that clinical judgment. The final say has to be the human in the loop and pair specific nuances, right?
Well, and I think
Um,
that we also are still getting, I don't know about you, but I'm still getting certain acronyms that I've never heard of before. I'm like, where'd you get that acronym? They're like, oh, that's just internal, or, a certain
yeah,
local jargon or medical specialty medical, medical language, even terminology, that is abstracting that maybe is new, or,
yeah,
and I think what you mentioned something too, as far as who's making the medical decision. I think when it comes to medical decision, and I hate to always call it common sense, but it's the physician common sense, their understanding. It's not always objective, it's subjective and requires a degree of interpretation.
hundred
And
percent,
I don't
hundred
know
percent.
that AI is quite there yet with that
No,
completion.
yeah. I mean, even documentation, right? Like I was auditing this interventional pain the other day, and the coder there, they had a bunch of level 2 notes.
Oh, man.
Okay. I'm like, this is interventional pain, and your patients are like pretty sick. Everybody has at least two or more chronic conditions. So, in how do you justify this? And then they were just scratching their head. Like I said, okay, look at this patient. Doc prescribed baclofen. She has two chronic conditions. One is exacerbated. So why is this a level 2? But she's like, oh, but the baclofen is like, she's already been on it for a while. So we didn't think we need. I'm like, nope.
Exactly. It's like if you're still making that decision to have to continue medication and why and they're not at goal, then you're still going to get credit for that.
Exactly. So, I mean, the note is not great. So how is AI going to make that determination? It comes down to somebody who understands the nuance and the specialty and the kind of work the provider does. So,
Well, there's other things that I'm running into too, and I don't know if you do. So you audit medical records like I do?
yes, my team does. Yeah, I also do, but yeah.
Yeah. So what I'm running into, and so I'm sure you're running into this as well. Medical records used to be kind of like what you and I are having, a conversation with the patient. But now there's filled with smart phrases, drop downs, cloned notes, and now with AI, it feels like it's a Harvard paper, not an actual encounter of what happened with the patient. And then I'm like, okay, well, let me see, because they're putting cited references and works in there. And Siri, some of them aren't accurate. I go and it's a broken link, or it's
Oh,
it's
yeah.
not to what they say, and I'm just like, oh my
Yeah.
gosh.
Yeah. No, it's almost like, the parallel I'd like to, somebody used this phrase is like, we are drowning in data, but starved for information. Some of these
Yes.
notes are like that.
Yes, they send you the Library of Congress, but you don't know what's in it.
Yeah. It's like there's so much verbiage, but hey, like, what am I looking at here?
What am I actually,
Where
yeah,
are the key
where do I
things?
find it? Yeah, and I
Yeah.
still have doctors that are, pulling in from a previous note things from like 12, 13, 14, 15 years ago. I'm like, keep it at 2 years. Unless it's absolutely pertinent to today, I really don't want to see anything past, 24 months. Now, if something that happened 3 or 4 years ago, is something that you really feel that you need for today's encounter, fine. But something, 10, 15 years ago, archive it, move on. But the other thing with AI is we do see a lot of hallucinations. It reminds me of my of my cell phone where I try to text somebody or I text like my husband and his name's Tom and it always says Tim. I'm like, sorry, that's the boyfriend. You're the husband. And he laughs at me all the time. But when you're trying to say ruptured Achilles and it automatically puts in appendix or something or spleen,
Oh, yeah.
and I don't see the doctors checking. And you remember the thing that came out when we got the new E&M guidelines, patients over paperwork. So
Mm-hmm.
the point of not requiring a specific exam in history, but you still had to have a problem pertinent one, was so that the physicians would spend more time with patients. And all it did was free them up to get more patients in. So now seeing, 3 patients an hour or 4, now they're seeing 6. And I'm still seeing mistakes, and now throw AI into it that tries to anticipate what you're going to say, and nobody's checking on that. Are you running into that as well?
Yes. Yeah. Again, but because we're also rev cycle, I usually educate my providers. So the audit is something, we do uh, routinely, and then sometimes we are brought in just to do audits for different practices. But with most of our rev cycle clients, this is like the housekeeping hygiene thing that I tell my providers always, sure, you're using this dictation tool, you're using your group normals, you're using your drop downs, but it's your malpractice, it's your liability, you are the person. And that is a tool, and that's what it is. It's a tool. It's not going to replace you. So you need to have either us, someone in your office, somebody has to go through those notes, or you yourself go through those notes before you put your signature on it.
Right. Well, and the other
Because
thing
if there
too.
is a Medicare audit tomorrow and they ask you to produce all of this documentation, uh-oh.
Yeah, yeah, exactly. Well, and the other thing I'm finding too with AI, and this is, I think, probably one of the biggest things that I think coders, billers, auditors, and healthcare professionals should feel, comfortable that they're not going to be replaced, that AI is an enhancement, is that code sets, coding guidelines, payer policies, documentation requirements, they're regularly updated, and especially for new medical advancements too, and changes to insurance coverage, new state and federal regulation. And logistically for AI, they aren't that real time updated. We are. So I think that that also is helpful to know that, you said something, I saw something on your website that said, if you want to, I'm trying to remember what you said, something about if coders and billers want to, stay updated in the field, they need to empower themselves to make sure they stay updated in the field, because in real time, we're more updated than some of the AI stuff.
100%. Like I had this happen where a client came to me. They were looking for a replacement code for, I think it was a Bardy cam or a ZO monitor. It was a cardiology practice. And then, they, I think, asked ChatGPT for it. And ChatGPT threw a code at them. But guess what? That code was deleted in 2015.
Yep.
So so they send that code to me. They're like, "Hey Siri, could you like have your team check if we can?" I'm like, "I know this code is deleted." And then I check and I'm like, "Yes, this code is deleted." So that's the AI hallucination, right?
Right. Well, I had the same thing with Google. I get coders
Yeah.
Googling codes all the time, and I'm like, hey, that angioplasty was
Yeah.
deleted. That was updated in 2015.
Yeah. So I think in terms of the future, the way I see it, Terry, I think it's going to be, as I said, collaborative. And I think AI is going to handle all the repetitive high volume tasks. And then we manage the exceptions, the compliance, and the strategy and the quality, right?
Yeah. Yeah. Now, let me ask you a question, since you are probably more tech savvy than me and working more with AI than I do. So, I mean, I was really excited to have you on the podcast. So, one thing that's come up, and I'm noticing I'm not seeing it in the medical records, is that if you are using an AI co-pilot, let's call it, because I know that's also one of the softwares out there, don't you have to get consent from the patient, because they are going to extract information to help build an AI platform? And where's the privacy if you're not positive that they're not going to name the patient or not make it so specific that somebody could recognize that patient record?
Yeah, and I don't quote me on this, but I do recall um, reading about the need for legislation around using AI because I don't think there is a very strong framework today. So even in terms of patient consent and such, I think it's all a very gray area.
Yeah, I think so too. I really try to insist. I said, if I see that you guys are using AI for your medical records, I also want to see consent in that record. So one practice said, "Well, tell us where it says that." And it's kind of like you said, it's a gray area, a little ambiguous, and it's recommended by AMA. The Office of Civil Rights says you need to have it, but as far as Medicare, they're like, well, of course that should be in there, but they haven't made like a published guidance. Well, then, of course, there's something breached, and two Medicare Advantage plans basically took money back because they said you're in trouble. And so, I think you really have to. And again, this is to our listeners. When there's automated systems and there's data being floated around and listened to, and your AI systems, they never really were impervious to security risks and assaults, but AI is capable of machine learning and deep learning techniques based on information that's being fed to them. So you have to require a strong PHI security measure. And hopefully this even gets even more into the HIPAA security because it worries me. It really does.
Yeah, 100%. 100%.
Now,
Uh,
what are the costs involved of implementing AI into a medical practice, and where should somebody
so
start?
today, I mean, within our own organization and things that we are recommending to our clients, um, enterprise is different, but with independent practices, it's actually because they, again, are running pilots. It's not, none of the tools out there are fully client ready, if you know what I mean.
Yes, I
Like with
do.
agentic AI,
Yeah.
sure, it can do the scheduling. Yes, it can accept payments, but to build those workflows and things like that, they need so much input because each practice is unique. Their financial policies are unique. There is so much input that's coming from the providers themselves. With all of these newer companies, they're giving it at a lower cost. So right now, if you're an early adopter of technology, there is that too. Because they want people to buy in. So I don't know the dollar amount to it because I've seen a range depending on scale. But with a smaller practice, you could do it just, with a few $1,000s. It's not crazy. There is a lot of investment that's going into AI. So what they want to do is consumer buy-in, physician buy-in, so that they have more numbers. So if you adopt this technology early, you could actually be saving as opposed to, once it's a lot more mature, where the price, they may price it differently. But today they just want you to start using it.
It reminds me of what was it oh my gosh, okay, I'm going to age myself now. Remember when we first integrated electronic medical records? I think it was early 90s, and they paid providers to do it.
Yep.
And then they came, I don't remember what it was called. I'm not remembering it. But then they all of a sudden said, okay, now you should have it and you don't get any,
Uh-huh.
benefit now. So I think this is very similar that, get it on the ground floor. At least some of the things that you're doing, probably at least start it so that, like you said, you're not going to get that technology high cost hit eventually. So I have a just to wrap up this conversation. I really like this conversation. So I like you had mentioned, there are some roadblocks. It's very new. It's in the infancy stage, but a lot of practices have already adopted a lot without knowing, kind of the pitfalls sometimes, and it's making remarkable progress. But to me, it's almost like a freight train, and I'm a little nervous
Oh
about
yeah.
that. But,
Mm-hmm.
and technology still has a long way to go before we can entrust it with our lives.
Mm-hmm.
But what would you, um, say to any coder, biller, revenue cycle management professional right now that is thinking about getting out of the healthcare field or RCM and going into something else because
no.
they're worried about AI?
No, wrong move. Don't do
Yeah.
it.
Okay.
What you do want to do, and this is for the coders and the billers, is to educate yourself, make yourself indispensable, because the jobs that I'm envisioning are going to be AI trainers, right? As these softwares and these tools get more and more sophisticated, they're going to learn, like you said, that machine learning. It's human beings teaching the machine,
Right. Right.
right? All of the exceptions. So AI trainers, AI RCM analysts, quality auditors, RCM automation specialists, AI workflow integrators. Like those are all their roles are going to evolve. So you want to keep, your eyes peeled, your ears open to everything that's happening. Stay on top of it. Get additional AI enabled whatever coding certifications that you need to, but coders and billers are here to stay. But it is going to be very much collaborative, so it's important that we stay with the times and keep learning the technology.
Yeah. And
But the
remember for
jobs
our
aren't
listeners,
going anywhere. They're
yeah.
definitely going to evolve.
Yeah, and you have to kind of keep up with the times. I mean, remember, well, I'm not sure. I think you're a little younger than me, but I remember fax machines that had that rolled paper on the floor. I miss my BlackBerry. I have to say, I liked filling the numbers than my iPhone. We used to have doctors on pagers, and now they're text. So, IT is always going to advance, and this is another advancement in that.
Yes.
But the one thing with this administration, one of the good things that have come out is that there's some AI trade schools out there, and you can now get funding for that. So if anybody's thinking about doing that, they weren't always funding that, only funding universities. So that's a good thing. They have a
Yeah.
lot of, programs that are 6 month, 9 month, 18 month, and you can actually get some funding for that. So for those medical professionals out there that want to keep up with the times, I think both myself and Suri would like to see you stay in the healthcare field because we're actually short staffed now.
Oh,
and
yeah.
and we definitely need you to stay, but need you also to really think about implementing and developing your skills to manage the changeover and make sure that it is going to have a changeover, but you're going to need to just keep up with the times.
Absolutely.
Okay, great. Well, Sarisha, I'd really like to, thank you for being on the podcast today. We appreciate your insights into this important topic of business of medicine, and I hope to have you again.
Likewise. Thank you so much for having me, Terry. It's a great conversation, and I look forward to being back on your podcast.
Great, thank you.
And
You,
everyone, thank you for listening to us.
you can find the contact information for Sarisha at nschbc.org. Find the consultant tab, type in Sarisha's first name, and there she is, Sirisha. As a reminder, the nschbc.org website offers monthly free webinars on a variety of topics, as well as a quarterly Medicare webinar update. For all educational offerings, go to the nschbc.org and click on Upcoming Education tab. That's it for me today, folks. Please join me next month when we once again bring you current and important topics in the business side of medicine. Everyone, make it a great day, a great rest of your month, and thank you for listening to the award-winning NSCHBC Edge podcast. I'm your host, Terry Fletcher.
Thank you for listening to the NSCHBC Edge podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.